Welcome to Dementia Resilience with Jill Lorenz, a candid conversation as we learn about dementia, Alzheimer's, and its effects on the people we love. Jill's years of dedication and experience help you adapt, recover, overcome obstacles, and help find a positive outcome. It's time for Dementia Resilience with Jill Lorenz.
Well, good morning. I hope everybody's having a great day. I've got a great show planned for you today. I've invited Dr. Samantha Holden back to be on the show. She is the Assistant Professor of Neurology at the University of Colorado Hospital. Welcome, Samantha.
Thank you. Very happy to be here.
I'm glad to have you here. So tell us about the different units that you work in. What areas of the hospital are you in the neurology clinic?
So I've been here a little over 4 years now, and I'm both in the Movement Disorder Center as well as the Memory Disorders Clinic.
Okay.
I treat people that have both movement problems as well as thinking and memory problems.
Okay. So you're working with Dr. Woodcock, Dr. Potter, and probably Dr. Kluger?
I do. I work very closely with Dr. Kluger.
Nice. He's one of my favorite folks.
Me too.
With his long hair and his bicycle and all that stuff.
He's a very special person.
Well, Samantha, I hope I don't embarrass you here, but I have heard just wonderful things about you. The docs out there seem to think you are the up-and-coming person to watch.
Oh, thank you.
And I'm really proud of you as a young woman that, and I hope that sounds appropriate, but as a young woman in the science field, there aren't that many young people in the science field, let alone women, and I'd like to see more.
Absolutely.
Yeah, but your specialty, I think, is Lewy body. Is that correct?
That is my particular area of interest and expertise, yes.
Okay. And do you work in other areas off of that, or is that just really your main focus?
It's my main area of research clinically. I also see patients, though, with Alzheimer's disease or frontotemporal dementia or brain injuries or other forms of tremor or movement problems in my clinic. But what I'm particularly interested in are the Lewy body diseases.
Okay. So many people have never heard of Lewy body. In fact, I don't think a lot of people even heard of it until Robin Williams the comedian, passed away. Yeah. And there was just a lot of confusion around it. Can you explain what Lewy body is? And then we'll talk about how it's related or different than other diseases.
Sure,
okay?
Absolutely. Yeah, so I wish it was under better circumstances that there was more notoriety around it.
Me too.
But a Lewy body is a small little bubble that we find in brain cells after somebody's passed away, first described by Dr. Lewy back in the 19th century. And inside that bubble is an abnormal protein called synuclein. So we can't know if somebody actually has Lewy bodies in their brain until they pass away and we look with a microscope. But in life, a Lewy body disease is either a Parkinson's disease or the related condition of dementia with Lewy bodies.
Okay. Wow. That's kind of a big area to understand. I guess that's the best way I can say that. So Lewy body sometimes represents itself as one of the more difficult dementias to work with. When I'm in care communities, I see this a lot. And it seems like they have more behaviors that are not triggered.
Yes.
Is that my imagination or is that true?
No, I think that's fair. Yeah. So in dementia with Lewy bodies, somebody has thinking and memory trouble early on. They also have some signs of Parkinsonism, meaning looks like Parkinson's disease without being Parkinson's disease, which is slowness, stiffness, shakiness, trouble with balance. And then they often have visual hallucinations, seeing things that aren't really there. And then these pretty significant fluctuations where 1 minute they might be totally sharp and with it, then they're out of it. And then they're a little suspicious and confused, then they're back in normal. So those big ups and downs that have no trigger can be very difficult for people to deal with and understand. But it's a big clue for us to diagnose people correctly.
Right. So why have they been confused with people with Alzheimer's type dementia? Now, just on the education piece here, I want to point out that Alzheimer's, we believe, is called by the beta amyloid plaque that causes the tangles and so on and so forth in the brain. Well, this synuclein is completely different.
Yes.
Right? Yeah.
So the problem is a lot of people conflate dementia, which is a broad umbrella term, meaning someone has enough thinking and memory trouble that their function's impaired, with Alzheimer's. Everybody just considers, oh, well, it's dementia, it must be Alzheimer's.
Right.
And it's not. It's the most common cause. It's about 60 to 70% of cases, but there are many other forms of neurodegenerative dementia. And the second most common is Lewy body.
Right. So it's odd to me that, and we've talked about this before on the show, but I'll bring it back up. My mom, she had very strong Alzheimer's type symptoms, and yet she really did not have any plaques and tangles upon her death.
Yes.
So, Samantha, I just ask you, I think this is a broad question, but it really makes me wonder, and I just want your take on it. If such a small percentage of people ever have an autopsy, how in the world can we be certain that 60 to 70% is really Alzheimer's? It could be Lewy body. It could be hippocampal sclerosis. It could be something else.
Yeah. No, you're exactly right. Yeah. And there is kind of a big taboo around autopsies in this country. In other countries, it's not like that. And I often talk with my patient. It's not a pleasant thing to talk about. But if we really want to be sure what somebody had in life and for us to learn more about it, then we need to actually look. And a lot of people talk about brain donation, but we don't necessarily need to go that far. Even just looking and seeing what was in there can really help us figure out what people look like while they're alive so we can diagnose it better while they're alive.
Well, that's interesting, too. When I've had Hunt Potter on the show, Dr. Huntington Potter, he has said he doesn't need everybody's brain.
Yes.
He needs people who are in the clinical trials and the studies that you have. And you can do that on trialmatch.com. But it's important that they study that person's life because then it doesn't make any difference if they have their brain posthumously.
Yeah.
What they really need is the information that leads up to it and then seeing if the autopsy results match, right? Yeah.
Exactly. Yeah.
So interesting stuff. So what are some of the symptoms that you would say, just clarifying for somebody that has a loved one with Lewy body or they've had the diagnosis?
Yes. So whenever I see somebody in my clinic coming in with complaints about their thinking and memory, or their partner has complaints about their thinking and memory, more usually actually, my questions kind of first start about what kind of things are you noticing? Because everybody kind of lumps memory for everything. But when you kind of piece through things, maybe it's not so much memory, maybe it's language, maybe it's visuospatial function, or what we call executive function, planning, multitasking, insight. So I try to suss that out better. And then I examine everybody for signs of Parkinsonism, even if it's very subtle, because in people with dementia with Lewy bodies, it's usually not this big, obvious tremor that people with Parkinson's have. They're usually not falling down. And then another really big clue is sleep. I ask everybody about sleep.
Right.
And the one question I ask is, do you suspect or have you ever been told that you act out your dreams? Kick, punch, yell, thrash around. And not just, sleep talking or even sleep walking. That's separate. I want to know if you're acting out your dreams.
Right.
That is called REM behavior disorder. And it is very, very strongly linked with Lewy bodies in the brain.
Wow.
If you act out your dreams at any time in your life and not, again, sleepwalking, sleep talking, that's different. There's a 97% chance there's Lewy bodies in your brain, and you'll eventually have some type of symptoms if you live long enough.
Wow. So we're going to get into Parkinson's here in the next segment and how Lewy body and Parkinson's are related, because I just think this is fascinating, how these different diseases may look similar, different proteins kind of tearing up the brain, and even medications can make it confusing what somebody might have or not have, and that just gets really, really confusing. So when we come back, we're going to talk about you were at a Grand Rounds. You were giving the speech, the lecture at the Grand Rounds for the docs out at University of Colorado Hospital. I was there. I thought it was impressive, and I want to talk about what you talked about because I just thought it was absolutely fascinating. So we're going to take a break and listen to a word from our sponsor. But when we come back, we're going to get into those wonderful Grand Rounds, and that people can actually come out and listen to them if they want to.
Absolutely. And they're also on YouTube if you wanted to see it.
Cool. Well, we'll be right back. Hey friends, I'm excited to tell you about Pine Grove Crossing Assisted Living and Memory Care in Parker, Colorado. They set the bar high for person-centered care. They're locally owned, and they focus on exceeding their residents' expectations while providing excellent dining, housekeeping, and transportation services. Their care team with licensed nurses are available 16 hours per day, 7 days a week to ensure clinical needs are addressed as soon as possible. Check them out at pinegrovecrossing.com or 303-996-8000 and see how care goes into everything they do.
It's time for Dementia Resilience with Jill Lorenz.
Okay. I'm on the show today with, I hope, my new friend, Dr. Samantha Holden from University of Colorado Hospital, and you are the Assistant Professor of Neurology there, and you work with the Movements Disorders Clinic and also the Memories Disorders Clinic.
I do.
And I was recently at the Grand Rounds, and we'll kind of explain what that is. It's a big room that goes up at an angle, and lots of the researchers and docs at the hospital and from other places come to listen to other researchers speak on subjects. And I think you get invited to do that when you know your stuff. Yeah. And you presented one recently that I was at. Will you talk about that, please? I thought it was fascinating.
Sure, yeah. So last month in early July, I gave Grand Rounds just on updates in the Lewy body dementias, and really with the goal of clarifying things, because there is a lot of overlap, and words are kind of used in different ways and overlap in that way. And even among doctors, even among neurologists, there's confusion. So let alone among the community, there's a high degree of confusion too. So if I can educate the providers to share the word too, we can kind of spread the word as much as possible.
Yes. Yeah. So you talked about Lewy body. What were some of the things that were highlights from that?
Yeah. So there was actually an update of the diagnostic criteria for dementia with Lewy bodies in 2017.
Okay.
And there were some changes there in how doctors should go about diagnosing this condition. It is still mainly a clinical diagnosis, meaning that you come into the clinic and hopefully an expert evaluates you, and hopefully you have people that know you well with you. And they still require that somebody has dementia, meaning there's enough memory trouble and thinking trouble that someone's no longer fully independent. And then there are 4 core features of dementia with Lewy bodies. We touched on them a little bit in the last segment, but one is the Parkinsonism, that someone's a little slow or stiff or shaky, and it could be mild and only picked up by an expert.
Right.
The hallucinations, usually visual, people, animals. There are the fluctuations, those ups and downs, even in a couple of minutes. Everybody has good days and bad days.
Moods.
And kind of like alertness and behaviors can just kind of turn on a dime.
Okay.
And then the last piece is that REM behavior disorder, the acting out of the dreams.
Okay.
So you need at least the dementia plus 2 of those features to say somebody has dementia with Lewy bodies.
Okay.
So I very clearly go through those criteria every time I meet someone new, even if they're not complaining about, Parkinson's-like symptoms at all.
Right. So, all right, help me out we're talking about Parkinson's and Parkinsonianism, which is the shaking mostly, and the REM sleep issues and all that. Now, help me understand. If I'm wrong, you need to correct me, okay? But in the Parkinson's arena, we've got those synuclein deposits from the Lewy body sitting on the basal ganglia.
Mostly, yeah.
Where the dopamine is produced, and the dopamine helps us with our fluidity, right? Our movements and so on and so forth. Therefore, that's why we call it the movements disorders.
Yep.
But wow, how crazy is that? That you have Lewy body deposits, that particular synuclein protein, on that area where the dopamine is produced that causes the issues where there's a lack of dopamine for people with Parkinson's.
Yes. So, yes, and this is where it gets a little hairy.
Yeah.
And actually, in the newest criteria for just Parkinson's disease that came out in 2015, they're now saying that don't bother distinguishing between Parkinson's disease and dementia with Lewy bodies.
Wow.
It's somewhat of a false dichotomy, because when you look at the brain of somebody after they pass away of Parkinson's disease or dementia with Lewy bodies, you can't tell the difference, really.
Wow.
Yeah.
So what about this tiny handwriting, the lower audible voice that are different characteristics that you will look at for Parkinson's disease?
Yes.
Right?
Yep. We see those in Lewy body too. Yeah.
Really?
Usually to a less, and usually that's not what people are complaining about.
Right.
If somebody comes into the clinic and they're like, I'm falling down, I'm shaky, I'm stiff, we're going to think more Parkinson's disease. But about 30 to 40% of people that have Parkinson's disease complaints mainly with movement, also when you test them, have thinking and memory trouble.
Right.
So there's a lot of overlap here.
Right. And just to muddy the waters just a little bit more, again, with our Parkinson's people, they, and I know you're working mainly with Lewy body, but some of them get those tremors when they're young as 25, like a Davis Finney, for example.
Yeah.
But people that are older have more of the stiffness, the freezing, the shuffled gait.
Yeah.
Right?
Yeah, there's thought to be two kind of flavors of Parkinson's disease, a tremor predominant, which is usually younger onset and goes much more slowly. People can usually do very well for decades, like Michael J. Fox or Davis Finney.
Right.
Versus the postural instability gait predominant type, where people are falling, freezing, shuffling. That's usually an older onset and usually progresses a little more quickly.
Right. So frontal temporal.
Yeah.
I mean, wow. Can you tussle with a few more tigers here?
Yeah, I got a hard job. Yeah.
So our frontal temporal folks, and I've talked about my brother Dave on the show. He's been very, very positive with his disease and the way he is living with it resiliently, and we're really proud as a family to watch him with this. But not everybody has that same decent path. I would call it a decent path. It's not always great, but that is judgment and reasoning in the frontal lobe. We've got some attention deficit disorders going on here. I don't mean that to be like ADHD, but we do. Lack of impulse control, laser focused on certain things. That's a tough disease.
Yes.
You pick like two of the hardest.
Yeah.
What are you doing here?
I know. Yeah. When I tell people what I do for a living, they're like, ooh. Yeah. I'm like, no, it's great. You get to help people. Yeah.
But frontal temporal, let's talk about the BV for a minute, the behavioral piece. That's really tough because it doesn't really show any memory issues.
No.
And not always necessarily movement issues. It's more cognitive impairment. It's judgment and reasoning, sexual drive.
Yeah. And usually much younger than the people we're seeing with Lewy body and Alzheimer's, more in the 40s and 50s than the 60s, 70s, 80s, which is, in the prime of somebody's life can be much more debilitating and distressing for people. But a lot of the times people will come in and just all the partner says is, well, this is not the person I married. And we hear that a lot where, personality changes, empathy is lost. And people can feel like, it's more of a discord issue, marital discord or family discord, but it's actually the changes in the brain. And because it's not as obvious and because it's younger than you would expect for a lot of the other neurodegenerative conditions, it gets missed a lot until it's very late. But the earlier we can diagnose and educate people and keep people happy and safe, the better.
Right. Well, I know that at your clinic there, Dr. Kluger and you and several, Christina Vaughn, she's been on the show before, you're really looking at a new way of meeting families where they are, a new way of bringing them in and talking to them so you can get a better diagnosis. And people often ask, what difference does it make if I get a good diagnosis or not? It may make a difference in the medications that are used. It may make a difference in how you're going to work with them with communication skills. But you've got some really cool stuff going on there. And so when we come back after our break, I want to get into that, how you're treating the family. I just think it's a fascinating piece, especially with our Lewy body friends and our Parkinson's friends, because it's a tough disease. And I'm so proud our Parkinson's friends seem to live with much more resilience and happier. I'm impressed with what you're doing, and I want to get into that and talk about it when we come back from our break. Okay, Samantha?
Perfect.
Thanks.
Living and working with Alzheimer's and other dementias can often be challenging. Summit Resilience Training provides education utilizing non-medical approaches for those who work with our friends affected by dementia. Believing families still need one-on-one assistance, we provide classes which help them understand the diseases affecting their loved ones, offering strategies and techniques for success with activities of daily living and working with confusing behaviors. We offer in-home assessments. Education programs instilling person-centered care philosophies are offered for professional caregivers working in communities and homes, which can be customized for their staff. Training is also available for first responders. We are passionate that people with dementias such as Alzheimer's, Parkinson's, and others are approached with compassion and understanding, and those who work with them have all the tools they need for success. Call us at Summit Resilience Training, 303-420-6988 to schedule a class or in-home assessment. Visit our website at summitresiliencetraining.com for more information.
It's time for Dementia Resilience with Jill Lorenz.
Okay, thanks for sticking with us today. I'm with the Assistant Professor of Neurology, Dr. Samantha Holden from University of Colorado Hospital. And Samantha, your area of expertise is Lewy body and how it interacts with Parkinson's disease and Parkinsonian-style symptoms and things like that. But you also work with frontal temporal. I forgot to ask you a question in the first segment. The medications that they give, we know that they're not preventative. We know they're not cures. We're talking about Aricept and Namenda and Excelon. And so Aricept and Excelon are kind of the same ones, just
in the same family.
Yeah. Okay. So, but why is it that Aricept doesn't have much effect on people with Alzheimer's, but you are seeing some good results? I'll say that guardedly with Lewy body.
Yeah, it is. It's really interesting. Yeah. So with these medications, the Aricept and the Excelon, they increase a certain chemical in the brain called acetylcholine. It's very important for thinking and memory.
Right.
It doesn't change the course of the disease necessarily. It just helps with symptoms while it's in your system.
Right.
It is thought that in Lewy body, there's less acetylcholine floating around to start with. So if you boost their acetylcholine, there's more room for benefit there. So with any of my patients, I never push these types of medicines. It's always a decision we make together. The benefits are modest, but if there's any chance it could help, it might be worth a try. But I do somewhat more strongly suggest the use of Aricept or Excelon in people with dementia with Lewy bodies, because I do see more of a benefit in them. And then I also do see when it's stopped, like if another provider decides, oh, it's not doing anything, let's stop it. Sometimes people do a lot worse. And I've had a couple people end up in the ER after their Aricept was stopped.
Really?
So I do recommend people with Lewy body, if a neurologist started it, make sure your neurologist knows it's being stopped.
Right. That would make sense. Now, speaking of that, the way you all work with each other, when we were leaving for break, I was mentioning that the way that you're working with families now is amazing. I've never really seen anything like it. You will see less patients so that you can spend more time with them.
Yes.
So what are you and Dr. Benzie Kluger doing about this and doing different?
Yeah, so we're very lucky at the university in that we're somewhat protected against the kind of financial constraints of a private practice where you have to make money.
Right.
So at the university, we're protected with our research money and with state money. And we really want to make sure that we spend enough time with people, not only to get to know them so we can diagnose them well. You can't know enough about somebody in 10, 15 minutes to diagnose them correctly.
Right.
But also so that we can offer more supportive care for people.
Yeah.
And when I tell people what I do and they say, oh, that must be so depressing, you can't cure anybody. You can't cure anything anymore.
Right.
You can't cure high blood pressure. You can't cure diabetes. So what we do is we manage and we help people, and we're there as their partner to kind of walk through this journey. And while it might not be the life that they were expecting for themselves, living with a disease like this, it's you can still live your life just in a different way.
Right.
So really the focus of our philosophy of care, and especially Dr. Kluger's palliative and supportive care clinic for neurological diseases, is how do we help you live your best life even in the face of this condition?
I love that. So how much time do you actually spend with a family?
Yeah. So in my own clinic, I get an hour and a half the first time I meet somebody. Yeah, which is very nice. Yeah. A lot of the time people are like, oh, well, we're taking all your time. And I'm like, no, we're good. And Dr. Kluger in his focused supportive care clinic, sometimes 2.5 hours the first time you meet somebody.
Yeah. I love that. I really do. What a difference What a difference from just coming in and having a conversation with somebody. You talk for a few minutes, 30 minutes later, you're like, oh, time's up, gotta go,
sorry.
right?
Yeah.
You just got started and you have to end. You don't get everything out.
No,
and not only that, but you're working with the families in a different way. I am so proud. Dr. Kluger has invited me out, and each quarter of this year, I've been providing classes for families.
Oh, wonderful.
On behalf of him and Dr. Julie Burke. And working with all of you has just been incredible because I am non-medical. I come from the opposite side. And Benzie's vision on this was he wanted somebody to come in and just tell the families how to communicate with each other, what signs to look for, how to make your house safer, how to be more compassionate in the way you're working with somebody, just using some clues of ways to make that person's life easier, from labeling cabinets to getting rid of throw rugs to just managing your own emotions and things like that.
Oh, and communication is so important because as dementia progresses, people lose the ability to communicate as we normally do, with sophisticated language. And a lot of times behavior and outbursts and, bad behavior is just somebody trying to communicate in the only way they can.
Exactly. So, it's an unmet need and they just don't know how to say it. So we've got a couple minutes left. What have we not talked about? What do you want people to know about what you're doing?
So a big piece of news actually is our memory disorders clinic is moving to a new site.
Really?
In Stapleton. So it's just one little office building, a 2-story office building. It's still a UC Health building, but it is a small, quiet, calm clinic. That's not the whole, stressful experience of being at the Anschutz campus.
Right.
And that's happening on the 27th of this month. So we'll be seeing our new patients as well as our return patients with memory disorders and other cognitive conditions and dementias at that new clinic at the corner of MLK and Quebec in Stapleton.
Wow. So who will be working with you there? Dr. Woodcock?
Dr. Woodcock, Dr. Pressman, Dr. Philly, and Dr. McConnell. So all of the memory disorder doctors.
Wow.
Dr. Kluger will be seeing patients over there once a month.
Okay.
We'll have neuropsychologists doing thinking and memory testing there. And then we might have sleep doctors. We might have other people helping us out there for mainly people with neurodegenerative conditions.
That's awesome.
Yeah.
And so you mentioned Dr. Peter Pressman. Yeah. So he's your FTD guy?
He is our FTD expert.
Okay, yeah. It's amazing to me that over the last, 10 years, maybe more, that we didn't used to see. I didn't say that grammatically correct. Whatever. We weren't looking at these different diseases ones. In different lanes prior to when?
Yeah. So even, still now there are some people who say, well, it's all dementia, it doesn't matter.
Right.
And that kind of stops my heart.
I know.
Because it's very important. And, where things used to be, oh, well, it's senility. It's old age. It's just senility. So dementia is not a diagnosis. Dementia just means someone's having enough trouble that they can't take care of themselves.
Oh, thank you for saying that. I spend most of my life trying to educate people that even dementia doesn't mean memory loss.
It does not.
And there are diseases under dementia, and then there are non-diseases under dementia. Yes. And it gets very confusing out there. But just to be clear, you've said it well, what the definition is of dementia. It does not mean a worsening of Alzheimer's. No. Alzheimer's, Parkinson's disease, Huntington, Lewy body, FTD, and even hippocampal sclerosis, different dementias under that are diseases. Yes. And there is no cure at this time. Please don't spend your money on these snake oil people that are telling you they can cure these things. If you want help, please call Dr. Holden. Please call the folks at University of Colorado Hospital, and they will help you. Samantha, you are awesome.
Oh, thank you.
When you were on the show in December, we didn't really get to get into all of this because we had a guest that was talking about her husband. But I think this is so important. And can I have you come back again sometime?
Absolutely.
And just shed some light. And anytime you have something new that you want to tell us about these diseases, you are welcome back.
Thank you.
Well, if you enjoy listening to these shows, go on Cruisin' 1430 on the internet, and you can look at the weekend programming and listen to the shows over and over again. Listen to what you like. Visit my website, summitresiliencetraining.com, if you want more information, a class or an in-home assessment or anything like that. And also, I load my podcasts on iTunes, Apple, Stitcher, Spotify, iTunes, and Google Play. So I said iTunes twice, didn't I? Anyway, go on there, like them, give me a 5-star rating, and we'll see you next week on Dementia Resilience with Jill Lorenz.
You've been listening to Dementia Resilience with Jill Lorenz. Visit her website at summitresiliencetraining.com to learn more, and join us next week as we learn more about dementia, Alzheimer's, and overcoming obstacles with a positive outcome. See you next time.